Hello, everybody out there. I hope you can hear me clearly. This is Professor Paul Sidhu from King's College Hospital in London. I'm chairing this webinar this late afternoon, and this webinar is basically on contrast-enhanced ultrasound. This is supported by the European Federations of Societies in Ultrasound in Medicine and Biology, and with support from BRACO. We will have 3 lectures today for you to enjoy. I will have the first lecture where I'll talk about how you can use contrast-enhanced ultrasound to reduce radiation dose, which will be followed by Professor Ping Liang, who will talk about the application of contrast-enhanced ultrasound in interventional ultrasound, and then finally by Professor Xi, who will talk about the intracavity contrast-enhanced ultrasound in clinical practice. You have the opportunity to ask questions online, and please do. At the end of the lecture, I will read out the questions and hopefully give answers to you. So I'll start off by talking about why we should be using contrast-enhanced ultrasound. The main aim of using any form of ultrasound is to reduce the radiation burden in the patient, as well as getting the clinical diagnosis. We are all familiar with this chart, where nuclear medicine thallium scans and interventional procedures have the highest radiation dose to the patient, and we know MRI and ultrasound have no radiation dose at all. The advantage of ultrasound over MRI is, of course, how much easier it is to use and how much more cost-effective it is. This is important long term, and this is a very important landmark paper published in the New England Journal of Medicine greater than 10 years ago, just showing you the amount of radiation that you give your patients, and in particular, pay attention to how much radiation you give the young child. This is a chart from the United States of America, just showing you how CT contributes to this increased radiation burden. Yes, it's helpful in the diagnosis, but you have to be aware of the amount of radiation you give to the younger patient, and more importantly, patients are now aware of how much radiation they are receiving with diagnostic radiology. It's estimated that between 1.5 and 2% of all cancers in the United States may be attributable to radiation from CT studies. And this is substantial, and we may not see this for a number of years hence. This is an important radiation exposure study in children, and this study, published in the Lancet, looking at over 300,000 patients, showed you that there is an excess risk of leukemia and brain tumors per 10,000 head CT scans in children. So the radiation is not trivial. We have now well-established uses of contrast-enhanced ultrasound in Europe, Japan, and China, and this is supported by a large amount of data, published papers, etc. In Europe, we use Sonoview. Levovis is no longer produced, but I understand that Sonosoid is available in Korea and Japan, but I'm not sure whether it's available in China yet. EFSAM has published many guidelines on how to use this contrast agent, starting in 2004 to 2008. In 2011, non-hepatic applications guidelines were produced, and an update on the liver. But more recently, we have produced use of contrast-enhanced ultrasound in pediatric practice and the update of the non-hepatic guidelines. And most important to all of this is the recent FDA approval in the United States for the use of contrast-enhanced ultrasound in the liver in both the adult and pediatric patient. And this is a landmark development. With these contrast agents available, why should you use it? Well, it has so many advantages over CT and MR. You can do ultrasound straight away. You don't need any laboratory testing. It's not renally excreted. And you can do it anywhere, bedside, operating theater, CT room, in real time, and you can observe it as it's happening. Is it safe? Well, contrast is very safe. This is an Italian study of 23,000 patients with a reaction rate of 0.0086%. And I show you this paper from mainland China looking at retrospectively at 30,000 cases using Sonosoid and essentially coming to the same conclusion of very, very low issues with reaction, etc. So it is safe and it's easy to use. So where would I use it? Well, I use it all the time to reduce radiation dose, as do many people. Ultrasound is the first-line investigation for the liver in many patients for many reasons, and particularly the worried well. And traditionally, you haven't given a contrast agent, as you think this is an invasive test. But once you add the contrast, it takes less than 5 minutes, may take me 2 operators, but it gives you the immediate answer, which is the most important. Is it accurate? We've seen it's safe. Is it accurate? Yes, it is accurate. This is a study from Degum in Germany, which showed it's as accurate as you possibly can to differentiate the difference between malignant and benign lesions, and very good for FNH and hemangiomas. And in the German healthcare system, it is cost effective. So we've got all the important things in place. So what about the incidental discovered lesion that comes into your clinic? Not the patient hasn't come from oncology, he's come from the community. Well, the vast majority of the lesions are benign, and if you can give that reassurance immediately to the patient, you should do so. And adding contrast helps. In Great Britain, we have the National Institute for Health and Clinical Excellence, NICE, and they recommend that we use contrast-enhanced ultrasound in different scenarios wherever ultrasound is inconclusive, if the patient doesn't want to have or cannot have CT, and also in the evaluation of HCC. So we have government body recommendation that you should use contrast-enhanced ultrasound. Let's just look at an example of a 38-year-old female patient from a general practitioner, abnormal liver function test and an epigastric mass. This is what you see on ultrasound, a big mass in a fatty liver. But once you add contrast agent to this, you will see immediately that the diagnosis is clear. There is that stellate star formation of an FNH. And as you go on, it remains hyper-enhanced and the remaining scar is in position. And this is the corresponding CT and MR confirming your diagnosis. But what you've done here is made the diagnosis immediately, really not needing to go on to further imaging. And this is so classical to see that star coming out, spoke wheel star in an FNH. Second patient, abnormal lesion in the liver, in the gallstones in a 45-year-old female. Injecting contrast, this atypical B mode example is a hemangioma. And again, classic appearances of puddling and filling in from the periphery. So you have saved these patients any further investigation because it's so pathognomonic. And the same for hepatocellular carcinoma, the hypervascularity, basket weave pattern, feeding artery, and late washout. And you can use the LIRADS classification for CUS to actually look at these lesions and classify the HCC, all without needing any other imaging. What about using it outside of the liver? It's not licensed outside the liver, except in peripheral vascular, the breast and in the heart, but we use it regularly off license, and we use it in, and the recommendations on the EFSAM is that you can use it both for carotid and aortic artery disease in the follow-up of aortic aneurysm repairs with EVAR and endolead. EVAR, endovascular aortic repair, is now preferred as an alternate to the open repair, but you need lifelong surveillance with CT for early detection. You want to avoid doing those CTs, even though they're elderly patients, because you can reduce the amount of radiation. This is an important study looking at the use of contrast-enhanced ultrasound in patients undergoing EVAR, showing you that contrast is actually a better imaging modality than CT. In this group, there was endotension where the sac didn't go down, but had no leak on CT, but the ultrasound with contrast demonstrated a leak in 9 out of 10 of those patients, showing you that it's more sensitive. And these are the sort of exquisite images you can get of endoleaks following an EVAR. So this really should be where you should be using contrast. This is a specific case of an endoleak on the angio table and on the CT. But if I show you the contrast-enhanced ultrasound imaging of where that contrast is coming from, you can just see that leaking through the porous material of single microbubbles, and how important this is to actually show you in real time exactly where that's all coming from. You can see it from the beginning. Exquisite demonstration. We also use it in blunt abdominal trauma and particularly in children. We establish the site of injury on CT, and then we add contrast, because adding contrast improves the diagnosis tremendously in comparison to the B mode. And examples of young patients with shattered spleens coming in for contrast-enhanced ultrasound, and you can delineate the actual area of infarction and trauma very, very clearly. So it's a useful tool in trauma as well. Traditionally, you've been comparing unenhanced B-mode ultrasound with the CT enhancement, but the addition of contrast makes that interpretation so much easier. You don't see the laceration in the spleen here so well on B-mode, but absolutely clearly on contrast-enhanced ultrasound. We now follow up all our patients with single organ injury with contrast-enhanced ultrasound, looking at this injury rather than CT. And in the young patients, these are the patients more difficult to be a proper interpretive CT because there's less body fat in the child, and the B-mode ultrasound doesn't really show up very much. That same patient who's developed a pseudoaneurysm, which you can pick up on the contrast-enhanced ultrasound and manage it appropriately. And this is entered the guidelines and in a number of publications to show that it should be used in an alternative in the stable patient to CT. But there's still some physician desire to image with anything else other than ultrasound because they feel more comfortable with this. But you should be able to say to the physicians, the expense of this procedure and the healthcare costs should not be underestimated. And it's also good clinical practice to involve an ethical approach to patient care, knowing that you have something that will not cause any harm to the patient, with radiation burden being central to this concept. And this is a paper I show lots of my residents and when I'm teaching, is that can you look at a parent in the eye when you're ordering a CT scan, is it safe for my child? So when the parent asks, doctor, is a CT scan safe for my child? We should be able to look the parent in the eyes and let them know that we have worked to ensure that their CT is necessary and that you've done every other imaging test beforehand, which includes contrast-enhanced ultrasound, to assure the parent that it's safe and necessary, bearing in mind that radiation dose risk from that CT to the younger patient. Thank you very much. Okay, I'm going to, I haven't got any questions coming through on here, on the thing. So if there's no questions, I'm going to move on to the next speaker,